I would like to welcome everybody to today's webinar, ACO and MIPS, What You Need to Know. My name is Scott Mash, and as always, I am joined by my good friend and partner in crime, Miss Cathy Costello.
Hey everybody, how are you? Thanks for joining us today. I just wanted to say as we got rolling that you probably thought if you've attended a gazillion webinars on MIPS that you had a handle on what you're supposed to be doing. And if you're a, quote, advanced APM, that you didn't have to do any more on MIPS. Well, the reality is, and this is what we're going to do today, is in true CMS fashion, you can't look at just one program, because CMS is noted for not integrating their message if you're involved in more than one program. So you have to overlay what you're doing to make sure you're meeting every single program's requirements and getting the greatest benefit out of those. So with that, we're going to roll in, look at the ACO reporting, look at the MIPS reporting, and see basically where you're supposed to be for 2017.
Now, we borrowed this graphic from the New England Journal of Medicine, made a few tweaks to it, but what this graphic is intended to show is how MIPS and other factors influence the practice and work decisions. Also, those decisions at the practice or organization level will then influence outcomes, and then onto the Medicare population. But what you have on the right-hand side, the left-hand side in red, is we're provided this framework. So MIPS and MACRA, it pulls together multiple programs, and you still have you have a population outside of the Medicare patients as well. So you have all of these other drivers as well. The local market conditions, ACOs or APMs, and consultants, vendors. So those influence what's happening at the practice level. Those practice decisions that you're making around selection of workflows, how you're going to submit, how you're going to address those CPIA activities, and also your mix of patients, training and all that, those in turn are intended to influence outcomes, hopefully positively, where you're going to report your performance. Again, you're going to look at that performance ongoing to continually improve your outcomes, your staff morale, staff effectiveness, then will also have an influence on the Medicare population outcome. And the goal really is improve patient experience and outcomes while reducing Medicare costs and costs to private payers. Really, all you got to take away. The takeaway from this graphic is MIPS is not just an IT initiative. It's not a clinical initiative. It's not a quality initiative. It is an organizational initiative that requires a broad cross-functional team to ensure success. All right, so we're going to give you a lot of information about what's really, really required if you're in a MIPS APM. Now, think back to one of our earlier presentations. You have this overarching program called MACRA that has two paths. It has MIPS, and it has the Advanced Alternative Payment Model. What happens if your APM is not advanced? Well, then it's considered a MIPS APM, and it's going down the MIPS track. Just keep in mind these alternative payment models, they all flow from the CMS Innovation Center, which may be earmarked for some heavy changes under the new administration. And really the goal there is they're putting together really test programs. They fast track these programs through to see if they can try something that will make an easily demonstrated improvement to care while reducing costs. So those that we have circled are considered a MIPS APM.
And depending on their situation, they may also be an advanced APM, but they are at least a MIPS APM.
And the perfect example of one that goes back and forth is CPC+. If you are just doing CPC+, you're not in an ACO, that's an advanced APM, so you go down that track. If you're in an ACO, you lose that risk-bearing component to the CPC, which then puts you back into the MIPS APM track. Other ones we got circled here is the shared savings and next generation ACOs, which pretty much everybody on this call, we hope, is a member of one of the shared savings ACOs here in Ohio. We'll talk a little bit more about that later. Some folks are playing in the end-stage renal disease model. There's an oncology care model, but those that are circled are specifically ones that are or can be a MIPS APM. So when CMS is looking to see if a provider is or is not a member of an APM, pretty much, I say pretty much because there's always a caveat to all of these little guidances or rules from CMS, they're going to look 3 times. They're going to look March, June, and August to see if a provider is on one of the APM lists. The one caveat is the oncology care model. They look at, it's determined on time period participation. So if they look there, the participant lists are adequate for determining for determinations under QPP. You don't have to do any more work. You don't have to look anywhere else. If a provider's on the list at any of these dates and at the end of the year.
Yeah, and you don't need to do any separate registration for it. They just take what you've done for your shared savings program or another ACO participant list, but just recognize that any identification within the MIPS program, it tracks back to what you've done in your ACO program.
So where are we with ACOs here in Ohio? We're looking at ACOs, we're not looking at APMs here, even though there's going to be a little bit of overlap, which we'll get into. But at the end of 2016, there were 19 Medicare ACOs in Ohio. 12 of those were Track 1, 7 of those were Track 2. There were 2 on the list that were Track 1 that could move to Track 2 at the beginning of 2017, and that's just due to when they started up the ACO, when they stood it up. Now here's where things get crazy. We can draw a line between the 12 and the 7 because 12, Track 1, is a MIPS APM. It's a non-risk-bearing ACO. The 7 that are Track 2, they are risk-bearing, so they are considered an advanced APM. There's a new option that's out there that's called Track 1 Plus. That has a minimal risk-bearing feature within the ACO that then does make it an advanced APM.
But that is something that will just be coming up available to you all in your organizations to consider participating in at the beginning of 2018. And I have to say, in case you haven't picked up on this, everything we say is dependent upon no complete rollback of the regulations, but the reality is that the payment model and the advanced structure for workflow and chronic care management of patients are still going to be high on the priority list. So I do not anticipate any big rollback. There may be changes in timeline, but for what we're saying right now, the Track 1 Plus is going to be available at the beginning of 2018 should your organization decide to participate in it.
Now also keep in mind with those Track 2 ACOs, again, they're advanced APMs, so all of the participants get that automatic 5% bonus check, and there are no additional reporting requirements. So the potential Ohio advanced APMs, if they meet the eligibility thresholds and they can be considered advanced APMs because they are risk-bearing. Now the names that we're using are not the true ACO business names. It's just kind of a general name or an organizational name that we put with it. So if you see yours there and you're like, wait a minute, we don't call ours that. We know.
We're just trying to make it easier for you to track what we're saying, and we figured that you would recognize your organization rather than us listing every single ACO name.
So if the ACO does meet the eligibility requirements for an advanced APM, they don't need to do any additional reporting and will receive the automatic MIPS bonus, the 5% in a lump sum.
And when we say eligibility, what we're talking about is CMS is saying either you have a certain percent of your patient panel or a certain amount of your billing overall as an organization or an ACO is Medicare Part B billing. And so if you meet either of those prongs, then you fall into being an advanced APM for that year. Now, the requirements for whether you're an advanced APM or not is going to change at the beginning of each year based upon your billing for the prior year. So just keep that in mind. What we're saying right now is related to the type of ACO that you are, and not an absolute as to whether or not you need to report under MIPS.
For everybody else, and those listed on this slide, you are considered a MIPS APM. So these ACOs will have additional reporting requirements regardless of what you heard. The ACO does take care of your quality. They report the quality up, you've met that. We're going to talk today about the ACI and CPIA activities that you probably will want to report, because if not, your ACI is going to drop to 0. With that, I'll turn it over to Ms. Cathy.
Okay. I think the thing to keep in mind here is don't get in your head that you don't need to report, because even if you're one of these advanced APMs and you get the idea that, well, you're going to be receiving a MIPS bonus, there are really 2 tracks of reimbursement here we're talking about. One is the type of shared savings that you get through participating in the Medicare Shared Savings Program. That is one whole track of what you do. The second one is the MIPS track, and whether or not you're going to receive additional bonus. So the MIPS track is like, do you get a bonus on your salary for a given year, versus the shared savings, which is overall, how is the organization performing? Does it benefit CMS, and is CMS going to give you part of what you've earned or saved them back? So those are 2 different things, but recognize that in melding these 2 programs together, it is going to be necessary for every single ACO to be reporting under MIPS, whether or not you're automatically going to get a MIPS bonus or not, because you need that for your ACO reporting. The difference here is up until 2017, any ACO that's been participating with Medicare in a shared savings program, as far as their meaningful use reporting, which, as you all know, is a quality metric under the ACO. Everyone, actually no one, had to do any separate reporting for this, and the reason why was that the meaningful use programs, whether they were Medicare or Medicaid, pushed up to CMS the information that your providers had been attested for meaningful use. And so this gave CMS the information that they needed to calculate your bonus score for ACO reporting for meaningful use participation. And we'll look at that specific metric in just a minute as we go down the path. But what I'm pointing out for you is this year in 2017, this is the very first year that CMS will not have that database to work with, because people are not going to be reporting meaningful use the same way. Even if you're in the Medicaid meaningful use program, that does not qualify as for what you need to report for the ACO. The graphic here on the left side of the page actually is taken straight from a CMS information piece about ACO reporting, and it is ACO metric 11, uses certified EHR technology. And if you track that to the right-hand side of that box, you'll see that the information is supposed to come from the Quality Payment Program data. This is the new MIPS reporting. So it does not include your Medicaid information. It does not include any preconceived, meaningful use attestation that's done. It goes strictly to how you report in the QPP program for your Medicare participation. So everybody wants to be doing this. It's the first year that you will be required to report in this way. Let's see how this all flows together in what you're doing. I know you've seen this. Many of you have participated in our previous webinars, and it's the 3 buckets of what used to be called meaningful use reporting. Let's talk about how this goes with ACO reporting. the first bucket on the right, the hospital is still going to be required not only for their own internal reporting for the IQR program, but also for ACO. Every hospital who's part of an ACO is required to report meaningful use to participate in the ACO program, as well as any other additional hospital reporting program. The middle one, the Medicaid one, as we just mentioned, although you have to continue to report your Medicaid and meet your Medicaid thresholds for meaningful use, if you have providers who are still getting incentive dollars for that, is not going to count towards your ACO reporting. That is going to come out of the left side, which is the Medicare EC reporting. The way that this is to work, and I can honestly say that CMS has not put out a lot of information about this, but this is what was in the regs, and we'll see how it gets fleshed out. But right now, if you are part of an ACO, and let's say the ACO has, say, 5 different tax IDs underneath it, every single tax ID is responsible for reporting meaningful use, or what's now called ACI, for the providers under that tax ID that are participating in the ACO. So this is the one area where you are not going to be covered by what the ACO is doing for reporting for you. So you will continue to track your providers if they're going to be part of Medicaid. You will continue to track them for your MIPS reporting if you're a MIPS ACO, but you absolutely want to make sure that you are tracking this as part of your ACO reporting, and we'll look at the question of how that fits in just a minute. What CMS is going to do is every TIN in that ACO reports up the ACI. CMS is going to internally aggregate, so whether you have one TIN or you have 100 TINs participating in your ACO, CMS is going to take the score that was sent to them for that TIN, and they're going to aggregate them across all of them and determine exactly what the ACI score is for that ACO. And I'm sure you're thinking, what does that mean? You know, if I have an ACO that has a provider group that has 2 providers versus I'm a system that's part of that same ACO and we have 100 providers, is that going to be weighted equally? And the question is no. CMS is going to take into account the fact that you had 100 providers reporting, and this is the score that you had in that group, and versus this is 2 providers reporting, and this is the score that they have. So
a weighted scoring.
Right. It will score, but once they've established that score for the ACO, that is the score that is given to the ACO and all of its participants that were listed as participants in the ACO. So that's important to keep in mind. And what CMS has said, we've tried to get clarification on this, is that at this point in time, because everything else you're reporting under the ACO is reported as a group, your quality metrics, you know, the determination of whether you're considered advanced or not is made at the group level. Your ACI reporting should be at the group level too. So if you have 2 or 100, you should be reporting that as one set of metrics for everyone, since group reporting is coming in this year as an option for your meaningful use reporting. If for some reason your shared savings program ends before the end of the year, then each TIN is still responsible for reporting all the providers in their group to avoid any penalties. And if the ACO does not report their quality as required, then the meaningful use score will not be aggregated. It will be kept separate. technically, the clinical practice improvement area, which I know you all believe that you're covered with it, and you are to a certain degree, but you technically don't need to report CPIA as a category of reporting under MIPS, but you will want to report it, and we'll show you why. Please note a change in your ACO reporting as we start looking at the meaningful use element, or what is now called technology or ACI. Up until this year, the way that the ACO meaningful use quality metric was tracked is by the primary care providers who were participating. CMS was not looking at the specialists. They were only looking at the primary care. You may not even have been aware of that because you didn't report them, you just reported them as part of meaningful use, and you weren't thinking of it in terms of ACO. But the reality was, when CMS gave you points for that reporting, they were looking only at your primary care providers. Starting this year, they are going to include all your providers, both primary care and specialists, as well as those that you were reporting only under Medicaid. And this would be your nurse practitioners, your PAs, and your certified nurse specialists. It's really an important metric. You need to understand why you want to be reporting this, because I suppose in the theoretical world, you don't have to report meaningful use for ACO, because it's just one of 34 metrics that you can or cannot report on. But the reality is you get double bonus points if you do well in your ACO reporting for meaningful use. So you want to definitely get those bonus points. So make sure, no matter what your structure is for ACO, that you are reporting your technology values. Okay, now looking specifically at what you want to do, because there are going to be some elements that are going to affect what you or how you report. So this, again, is stage 2. We are going to assume, we have not heard of any groups yet that are planning to report stage 3 in 2017, so we'll just keep it at this level, which is stage 2. There are 4 areas that your group is going to have some score in. Obviously, your privacy and security, so you are going to have to continue to do that on an annual basis. E-prescribing, you actually don't report your e-prescribing value. I mean, you report it only in the sense that it's one of the metrics, but you aren't scored on it. It's just required that you be doing that. You still are not required to be doing controlled substance e-prescribing to meet this measure, but it's one thing that many groups are doing starting this year, next year. But for this purpose, for the scoring, you are just reporting your e-prescribing, your numerator and denominator. The third area that you have to be reporting on is that you're providing patient access through the portal. And that it means that you're pushing your summary of care, you're pushing your lab reports, your radiology is going there, and that you're giving access to the patients. The fourth area, and this one I really need to point out to you because I think many of you have been using the exclusion on this measure, but the health information exchange measure, or the referral of care, doing an electronic referral of your CCD document, is no longer an exclusion. You must be showing at least one patient record has been pushed electronically to meet the required base score.
Now, but note on that measure that you get double credit. So if you're able to get to the 20th percentile, you get to the 30th percentile, you're going to get double credit. So please incorporate that, the sending of the direct messages into your workflows as soon as possible. Get the care teams used to doing it.
Absolutely. I think that's so important to note, is that you do get the additional score for patient access and for electronic summary of care. So you get up to 20% of your total points. And just so you understand how the scoring is, there are 155 potential points in the ACI category to equal 100%. So you should easily be making 100%, but just make sure you understand the base score.
So, for example, with the provide patient access, folks would generally write around 80–90% for that measure. If you're at 80%, that's 16 points towards the 100 points that you need to get the maximum score under ACI.
Right. And then the other things to point out that are different, you still have your patient ed, you still have secured message. Those are not required, but clearly you want to be doing those because you get points for it. The secure message is the one sent from the practice to the patient and not vice versa. MedRec is the same. Note here the question of public health reporting. You are not required to be doing public health reporting, but you get significant points if you are. Now, practically everyone in the state is either hooked up to the Immunization Reporting Impact SIS program or they're in line to do that, and so you would continue to get points for that.
Yeah, and also I wanted to let everyone know that CMS has released the specs, the measure specs that we've been used to seeing in past years for meaningful use for these measures, and we'll be sending those out on our CliniSync Plus newsletter.
Yeah, okay, and then the other public health reporting for stage 2, the options were syndromic and specialized registry reporting, meaning the cancer registry in Ohio. Syndromic, please note, I'm sure we're going to get a lot of questions about this. Many of you were using the syndromic as your second option for public health reporting for meaningful use in 2016. You know, honestly, because it's not even going to be available for anybody in the ambulatory area except urgent care starting in 2018, I would not honestly report on that under MIPS unless you're actively reporting the syndromic. But the last area, and I think this is really worth taking a minute on, is this last area highlighted in red, and that is these bonus points that you get for use of your EHR as part of your clinical practice improvement area. And this is why we said earlier, even though as a shared savings program, you max out the 40 points that are necessary for CPIA for this year, the reality is you're going to want to report in this category, and we'll show you why. If you want to get 10% bonus points for use of your EHR system, then you are going to have to report the clinical practice improvement area that has produced that 10% to show that you earned it. And so there are about 50, a little more than 50 categories of continuing practice improvement area, of which they've highlighted, I don't know, probably about 20. These are the major categories that are then, if you report on that, then produces a 10% bonus for your technology use. And there are many, there's like diabetes management, anticoagulation management. A
lot of care plans.
Care plan, yeah, for both transitional care and chronic care management and stuff. But the thing I'd like to point out, if you look on the right-hand side of this, second one down, is use of the HIE. Every single organization, ACO, that has hospitals attached to it in Ohio are already using the HIE as part of their functionality. The hospitals, we have 130 live right now, and there's the rest are in queue. And so this would fulfill your requirement for CPIA as for your ACO reporting for technology. So If you need documentation, clearly that is something that you can use and fulfills different requirements, you know, that you are using technology. So that would be the easiest thing to do, because you only have to be doing one CPIA activity under these what are called EHR related activities to get that 10% bonus point as part of your meaningful use ACI technology reporting. So keep that in mind, that although you don't technically as an ACO need to do any additional CPIA reporting, you're going to want to report on at least one of these categories so that you can get that 10% bonus point as part of your meaningful use score. Okay, now on the quality reporting, I just want to show you for a minute how the quality reporting for the ACO fits in with the MIPS reporting, just so you have some idea of how you score. Because as you know, the scoring is you know, pretty significant on quality when you're getting judged for MIPS. So you're trying to get your physician scores up as high as possible so that if they are not part of an advanced APM where they automatically get the 5% bonus, the second option is they're a MIPS APM and you earn your bonus, and you want to get at least 4% and any additional that you can earn by increasing your points. So I'm going to show you how these fit together and what you basically get scored on. If you are an ACO that is participating in CPC Plus, you will continue to report both your site-specific information for CPC Plus, but that site will continue to be part of your ACO reporting for quality. Shared Savings has a list of 34 metrics, 14 that are non-CAFs and non-hospital based, and 11 of them are being used for MIPS reporting scoring. And let me emphasize this again. Your ACO quality reporting will continue on exactly the same way with the upgrade each year. You know, they make some tweaks on the measures. You will continue to report all of that, and you will do nothing different than that for your MIPS quality scoring. It's just that once you have reported that, CMS will take the results in 11 of those areas and use them to score your MIPS score for quality. In looking at the ACO reporting, as you know, there are 4 domains that go into your ACO score. So the first one is basically your CAP score for your patient satisfaction survey. We don't need to worry about that. That does not go into your MIPS scoring. It's something that will be done regardless by the ACO. The second area is the care coordination, patient safety. Most of these measures are the hospital-based measures on admission and readmission. But as you get down further on the list, this is actually where the meaningful use measure, what they used to call meaningful use, number 11, is now called Uses Certified EHR Technology, appears. And as you look to the right, you're actually only reporting for this year and for 2018 and being judged on performance in 2019. And the reason why is that the change to include the specialist in the metric under ACO scoring, CMS is not required to, or is not allowed to change a quality metric unless they've given 2 years of notice. So you will be reporting on all your providers, but you will basically get your bonus score for reporting by just reporting. And so you want to make sure that you've included all your primary care and all your specialists in your meaningful use reporting.
And that is by reporting at least 50% of the ACO participants, correct?
Right. Now, if you look at number 13, screening for future fall risk, that is the first ACO measure that is used to establish your MIPS quality score. Now, as you get into preventive health, there are a whole bunch of it. Almost all the preventive health measures are ones that go into the MIPS scoring. So it's flu, pneumococcal, BMI, tobacco use, depression screening, colorectal, and mammography are all wrapped up in what is developed as the ACO's MIPS score, okay? And again, you are reporting all the ACO measures as part of ACO reporting for quality. CMS is the one who pulls out the measures that are going to be used in the MIPS scoring. In the at-risk population, 3 of these are also taken into account for MIPS reporting. One's your diabetes composite, one's your blood pressure less than 140/90, so blood pressure good control, and one's IBD with aspirin control for your heart patients. So these are the measures that are actually going to be used to create your MIPS score for the ACO. And keep in mind, once again, that everyone in the ACO, regardless of whether they're with separate organizations or the same, is going to receive the same MIPS composite performance score, so CPS. These are the ACO measures that have been removed as part of 2017 reporting. 2 of the hospital measures, the COPD and heart failure, are not being independently tracked as part of the admissions. Documentation of current meds in the med list. This continues to be extremely important to drive your quality metrics. What it has been replaced with is not that you are not tracking it, but for the ACO, they're asking you to track the med rec post-discharge as opposed to in the ambulatory area. But you want to continue to track that internally because it drives so much of your other quality metrics. The other measures that were dropped for 2017 reporting, excuse me, is high blood pressure screening, follow-up, beta blocker, and ACE inhibitor or ARB therapy. Okay, now on the clinical practice improvement, just to reiterate, because we're really wrapping up the area and we want to get to your questions, but
yeah. So for those that are on the call that are participating in the Shared Savings ACO, you get full credit under CPIA. So again, technically, you would not have to report any of the CPIA activities outside of your work with the ACO, but you may very well want to get that bonus back in your ACI score. So if you're not at 100% when you work out the math on your ACI score, then by gosh, by all means, report your other CPIA activities that you have going on. Now, this is going to require that you kind of formalize the activity. You have documentation to back it up because we all know there will be audits.
Yeah, and keep in mind, the one thing that we need to point out about CPIA is that you are receiving the points for being part of the ACO, but for any other CPIA activity, you have to show that you have participated for at least 3 months in 2017 in order to claim it. So when you look through that list of CPIA activities, looking for ones that you can use for the 10% bonus, make sure that it is something that you have done for at least 3 months. And as I mentioned, for the ACOs, with all the hospitals that are integrated, that should not be a problem showing 3 months of HIE activity.
But if you roll over to the new calendar year and you're going to use of HIE activities again, you're going to want to show different activities or expanded or improved activities within that. So let's say for 2017, it's all about results. You're focusing on results delivery and incorporation into the medical record. Maybe in 2018, it's the query and retrieve functionality, or what's also commonly referred to as the IHE interfaces within many of the EHRs that you're going to implement, utilize, and
especially with stage 3 coming in. Assuming that there's not any changes in stage 3, and as I said, these are all big unknown questions right now as to how the change in what they're doing regulatory is going to fit in. But let's just take 1 minute before we close and move to questions to talk about the overall approach that was laid out in this last set of regs. So what you've seen presented today is really has to do with 2017 reporting. But please recognize that what the regs envisioned moving ahead each year is that they would incorporate more and more points into the program so that not only would you be judged on your absolute score in each of these areas each year, but that they anticipated looking at improvement, so your own improvement from one year to the next. So if you report on one CPIA activity this year, which is all you're required to do, next year you're going to want to build on that and show increased functionality or new program or whatever. And the same thing's true with the technology meaningful use area, is that although there are not thresholds in 2017, the regs did talk about moving back to thresholds in the next couple of years. Whether that comes to be, I don't know. I don't think any of us know. But I'm just pointing out to you that use 2017. This is going to be your easiest year for reporting. Use it as your time to get your approach together to work with your providers, especially as you move into stage 3 in 2018, to make sure that you understand all the workflow and how to utilize it to the maximum capability.
All right. With that, we're going to go to questions, and we have 2 questions right now. Is the ACI score from the ACO, the 10, or from the individual provider used when calculating the individual provider's composite performance score?
Well, let's just remind everybody that the reporting, as it's been laid out by CMS, is the ACI score, or not score, but the ACI reporting is done by each TIN. But CMS has made very clear, they talk time and time again about the group concept of these new payment models, and they specifically called out shared savings. And they said, even though everybody has to take part, the overall impact is that everyone is going to receive 1 score, because they felt that if you are an ACO, the purpose of the ACO is to provide better care for the patient community as a whole. And so whether it's a practice that's down the road from yours or right in the hospital, that everyone is going to receive the same score. So even though you may roll up with different values for the ACI that's reported by each tax ID number, the reality is that's all going to be pulled together by CMS, and you will receive 1 score for quality, 1 score for CPIA, 1 score for meaningful use or technology within the ACO, and this will all be pulled together as 1 composite performance score for everyone. So if you get a 65 for the group, it's for everybody in the ACO. If you have 500 participants or 5, it's still going to be 65. The goal here is let's try to get above 70, because 70 is considered exceptional performance and will receive the highest bonus scores in the MIPS program. So, but everyone in your ACO will receive the same composite performance score, good or bad, and that will then be determined as to what the bonus is to be set for MIPS reporting, not shared savings. Shared savings is totally calculated separately, but for the MIPS bonus, which, as I said, is like the add-on in 2019 for every single check that you receive, for every claim that's paid, there's going to be a bonus paid to you on that claim based upon your MIPS performance.
Okay, the next question is kind of a follow-up. So if we have a provider who's in an ACO, but they feel their quality scores are significantly higher than the ACO, can they submit their own quality reports under MIPS? And if they do, are they going to be judged on those individual scores or the ACOs for their composite score?
Well, we actually have at least one ACO who's testing that theory on the individual versus group. The way that CMS has stated it, they expect to see a group score. The reality is that every provider is being judged by a combination TIN, NPI, and so if you have separate tax IDs that you're reporting under, that you are going to get separate ACI scores for those, and the highest one wins. At least in 2017, CMS is going to give you the highest benefit. Now the question is, and I recognize what you're asking, is what if it's the same TIN NPI combination? If the physician feels like they are knocking it out of the ballpark and they are at 100 plus, they're getting close to 150 points out of the possible 100, why should they not be judged at the higher score? And all I can say is you can certainly submit, but CMS is looking for that group reporting. And they have not indicated that they are going to allow a separate scoring for a provider who's part of an ACO separate from the ACO reporting.
Looks like our last question is, do you need to register for the ACO?
No. The registration, CMS is trying to keep certain tracks together, and one is that if you're in any alternative payment model, whether it's ACO or one of these other ones, CPC Plus or some of the advanced ACOs, that any of those, your registration with CMS as a participant in that alternative payment model is going to satisfy the requirement for MIPS reporting and will basically drive what happens to you as part of the MIPS program. So your participation there will then trigger a determination about whether your payment model is an advanced payment model, because they will look at all the claims submitted by the providers in that ACO in the prior year and make that determination. But it's all done automatically based upon who was determined to be part of that ACO at the various points of registration during that year.
That was our last question. Cathy and I are always here to help. You guys know that. You're our clients. If you have any questions, you need clarification, you've got our contact info. Keep an eye on the CliniSync YouTube site, because we will be posting a recording of this webinar.
Okay.
And hang on tight, because we know there's going to be changes.
Yeah, we will let you know as soon as we hear any change in regulatory speaking, because normally the next set of regs would be out around May, and we just don't know until the new folks at CMS, not just CMS, but HHS get in place, Administrator Dr. Price, and the other folks. We won't have any idea of how this is going to change from 2017, but for right now I'd say just move ahead with the 2017 as it was laid out.
But regardless of those changes, you're going to be judged on quality, you're going to be judged on your use of technology. Monitor those scores, keep working with your teams, continually providing training, and just keep those scores as high as possible. Regardless of the change, you're going to come out good in the end.
Yep. So everyone have a great day, and we'll talk to you soon.